So first of all, thank for the invitation here. It's hard being here after all these great speakers, but I'll try to make my best. So let's start with some European epidemic data. This is France, where the AIDS cases are falling from 4,040 in 1996 to 1,000. And as we see, male-female ratio, it's still higher in male. The same it happens in Germany, where from 1,600 to 367, we see 48 female cases in 2006. These data are from the WHO epidemic fact sheets, so they are available online. Here we have Spain, from 6,700 to 1,500, and then United Kingdom from 1,400 and to 857. What is really interesting is to see that especially the decrease was among the IV drug abusers. Let's see, in Spain, we have 108 AIDS cases for million inhabitants among IV drug abusers, and 15 in 2006. In Italy, also we had 51 and then 5.3 in 2006. So let's see what happened in Italy specifically. In 1996, we had 5,052 AIDS cases reported, and 1,144 are in 2007. So this is pretty similar to what happened in other European countries. And here we have the risk group divided AIDS epidemic. So in 96, 97, we had 4,737 cases among the IV drug abusers. And in 2006, 2007, that's 680. This means this decrease is the main cause of the numbers that we see down there. That is 8,000 cases in 96, 97 that fall to 2,547 in 2006. And what means so likely that IV drug abusers develop AIDS cases more than the others? Maybe they are more infected by HIV. So what is a good way to demonstrate that IV drug abuse itself can play a role? It's to demonstrate causation and correlation with the AIDS epidemic. So let's see what the National Institute of Drug Abuse says about the use of heroin. The medical consequences of chronic heroin injection are bacterial infection, liver or kidney disease, pneumonia, and tuberculosis. And all bacterial infection, pneumonia, and tuberculosis are all AIDS symptoms. So this is something that is supporting the causation. Another thing that the NIDA says is that additives in street heroin can themselves cause infection. Moreover, in pregnancy, this heroin can give low birth weight. So for NIDA, causation is proved. And up there, you see in the graphic that just 20%, it's little, I'm sorry, it's just 20% of a heroin dose, the amount of heroin. So what's the 80% of a heroin dose? What we see in the impurity profiling of the United Nations is that the heroin adulterants that we can find in a heroin dose are, I would say, an entire lab. We can find chloroquine, methaqualone, many substances that have a pharmaceutical activity. And these photos that you see down there are photographs made by MD thesis tutor, that is Professor Giovanni Pierini, that is a forensic toxicology professor. And these are from heroin doses, and these things can go in vein. And this is a head of an insect, the one down there. The other one is the respiratory system and the exoskeleton of an insect. And up there you can see aluminium fiber. To prove correlation, I used the Parliament report on drug addiction in Italy that is made by the Italian government, the Drug Addiction Services report that is made by SCRT, that are the Drug Addiction Service in Italy, that depends from the Minister of Health. And then I use the AIDS cases and HIV infections report made by the Italian National Health Service, specifically by COA, that it's the center that specifically elaborates the AIDS cases data bank. So here it's listed also, but in Italy we have 92,000 that were treated by the SCRT in 1991, and now we have 173,000 that are treated in 2007, and the male-female ratio is still among 6:1 male for female. What is really useful in the SCRT report is that they report not only the data about the drug abuse, but also about the infections. So let's see, in the heroin abusers, we had as primary drug of abuse in 1991 heroin with more than 90%, and now we have about 70% of the prevalence in the Italian SCRT population that are heroin abusers. Specifically, intravenous drug abusers fall from the beginning of the 90s that were 80–90% till now that they are about 60% of prevalence. But what's the incidence? The incidence today is that 70% of the old users are heroin abusers, but just less than 50% are heroin abusers among the new users. And just 50% of them are intravenous drug abusers. So now there are more smoking heroin. So let's see a comparison between the peak of the AIDS cases and the peak of the heroin abuse. We can see that the heroin abuse peak happens a little bit before the AIDS cases peak happen, and then we have a decrease of the heroin abusers. But what is really important is that you can see that the graphic there, it's an estimate by the SCRT. This estimate is made because we had 25,000 heroin abusers reported in the middle of the 90s and 20,000 at the end of the 2008. But the point is that we had 172,000 people that is going to the SCRT now, and just 120,000 that was going in the SCRT in 1996. Therefore, I used the X-team to make a more specific comparison. Here we had the deaths for acute drug intoxication in the middle of the 90s that are a really strong indicator of heavy drug abuse. So we see a peak of 1,500 cases in 1996, and we see a ratio really big of male-female among 10:1, and this is something that is comparable with the fact that the AIDS is specifically a man pathology. And now let's compare with HIV. So if the AIDS cases can match better with the HIV prevalence or incidence. So here they give really cryptical data. They say that 55% of the patients tested for HIV in the 1991 and that 28.8% were positive. In numbers, this means that there were 14,762 cases in 1991, and we have 9,407 cases now. But the point is that now just 39% of the people is making the HIV test. So if we put this data at 100%, we can see that HIV prevalence was about 25,000 people in 1991, and now in 2004 and going on, we have about 20,000 cases, so not more than 10 or 2% or 20% of decreasal. What we know is that for sure HIV did not kill so many people, because there you can see the average age of the SCRT population, and you see that the population is getting older. So generally, you don't get older if you die. And here you can see a comparison with the AIDS cases, and you see that, for example, in 1992 we have 3,800 cases and 14,000 HIV positive, and in 2004 we had 9,400 cases of HIV testing positive, and just 1,600 AIDS cases. So there's no correlation between the prevalence. But let's see the incidence. We see the peak of the AIDS cases were from 1993 and 1996, we can say. And let's see where was the peak of the incidence of the HIV abuser. First of all, we have no peak, because if instead of the percent we put the numbers, and now we know that the patients are like the double of this number, we formally see that a 15% is kind of the same of a 7% in 2008. But what is really important is that we didn't have a peak in the early 90s of the HIV incidence, that we also can see that the female are testing more positive than men. And normally, men use more drug than the female and share more needles. So why they are testing way more positive than the men is unknown. And why are they developing less AIDS if they are testing more positive is also unknown. But maybe what changed in the AIDS cases, even if the HIV prevalence was the same, was the therapy. Probably this is, I would say, the main slide of my presentation. We see that the therapy is probably the only therapy that heals people without being given to the people, because just 34% of the people that is in pre-AIDS is receiving antiretroviral therapy. What this means? This means that if 30% is receiving a therapy, how comes that the cases fell of 60% or 80%, depending from the risk groups? And let's go deeper in the risk groups. We see that almost 60% of the IV drug abusers were prescribed the antiretroviral drugs. This is a mandatory data that you should report in your AIDS report. As you heard, it's mandatory to report the AIDS cases, but not the HIV cases. So when you report an AIDS case, you have to report also if the patient has had in pre-AIDS antiretroviral therapy. So we see that just 60% of the IV drug abusers were prescribed a therapy, and we know for sure that they are not compliant. According to Mario Negri's study, it's about 50% of compliance between this risk group. So how comes that you have a 80% falling when just 60% is taking the drug? It's pretty difficult. And how come that also in the homosexual that are taking just 20%, in just 20% of the homosexual that are taking the drug, how comes that the cases fell from 1,250 to 555? Probably a role was played by the poppers that, according to the National Institute of Drug Abuse and their monography, can cause immune system problems and also cancer. Specifically in the monography, they are pretty clear saying that it causes Kaposi's sarcoma. This is also data from the CDC and from the paper of Duisberg, Resnick, and Köhlein that clearly explain that nitric inhalants were the most common thing in the risk group of the AIDS homosexual patient, the homosexual at risk for AIDS patient. So let's see what the minister think about the drugs. This is the law that rules the AIDS case and how to diagnose an AIDS case in Italy. It's from 1994. As Dr. Ruggero said, there's this HIV positive, the diagnosis can be made in HIV positive patient with one of the 27 famous symptoms, or even without HIV. And as Dr. Ruggero say, high dose or long-term corticosteroid therapy or other immunosuppressive or other cytotoxic therapy should go in differential diagnosis with the HIV for causing these symptoms. So Cytotoxic therapy is considered to be a cause of AIDS. So why are we giving AZT that was invented by Horvitz in 1964, if I'm not wrong, for curing leukemia, and it was too toxic for curing leukemia. This is what we see in the AZT disclaimer, but already Dr. Resnick showed it. But I think it's really important to see in the myopathy what the warnings say, that it's the myopathy is similar to the one produced by HIV. So how you can make a differential diagnosis, nobody knows. And this is the astonishing warning that you can see in the abacavir, especially in the sexual medication guide, where they state Zygan does not cure HIV infection or AIDS, and Zygan has not been studied long enough to know if it will help you live longer or have fewer of the medical problems that are associated with HIV infection or AIDS. And this is the medication guide. So my last slide will be just to point out that there is not just one cause of this symptom. We can have, for example, cotrimoxazole, that is trimethoprim, and sulfamethoxazole that causes the same symptom of AIDS, causing hematological problems. Or we can have, for example, methotrexate that is used also in arthritis that can give also immune suppression. So what is really important to see is that it's just about the dose of the poison that you give. It's not the poison that make the problem, but just the dose. So in this slide is reported also in the last column, the lethality. So we see that the lethality is going lower and lower, but what is really important to notice is that now, even if the so-called cocktail is less toxic for sure than taking 2 grams of AZT, but we have a lethality of 8%, and this is the result, 8% a year. And this is the result that Dr. Curline had after 18 years with these patients. So the therapy as a result in really, 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 really worse than the one had by Dr. Curline that did not give the antiretroviral therapy to his patients. So I think that what Paracelsus say, it is the best take-home message that I can give you. And I think that the important thing is not to be fooled by the pharmaceutical companies or from the people that say that heroin or other toxic are not causing effects just because it's not published. I mean, the FDA states that, the NIDA states that, and we cannot ignore.